Athletes push limits. Our responsibility is to help them perform safely and sustainably. Scientific Session 2. Athletes aspire to more. Let's help take them there. Explores today's most pressing challenges in the athletic spine. From congenital spinal stenosis in contact sports to treating spondylosis and the growing epidemic of pars defects in children. From caring for the golfer's spine to guiding athletes after scoliosis surgery. We'll also take a critical look at emerging therapies, stem cells, PRP, exosomes, and growth factors, examining the evidence and appropriate indications. Through expert discussion and practical insight, this session focuses on what matters most, elevating the quality of spine care and helping athletes safely return to what they love.
Thank you for the opportunity to be here and talk about congenital stenosis and contact sports. So some work with the NFL, nothing really related. So I'll start with a case. All right, we all love cases. So this is a gentleman seen in our institution, 20-year-old D1 linebacker, NFL prospects. He's got recurrent left upper extremity pain, right? Really bad stingers that are becoming more and more common. You see his imaging there. He's got a small canal, about 11 millimeters. He's got some foraminal stenosis on the left. He was seen by a local spine surgeon who recommended a 2-level cervical disc replacement. We'll hit the pause button there and revisit this case at the end. So my objectives for the next 8 minutes are to define the question we've been tasked to answer, go over some literature and clinical pearls, and then go over some more cases. So first the question, congenital spinal stenosis in contact sports. So let's break it down into its parts and first touch on congenital stenosis. So what is congenital stenosis? In its most simplest terms, there's not enough room for your spinal cord within the spinal canal. We've binarized it, like we do with all things in medicine, and we say at about 10 to 11 millimeters, when the space available for the spinal cord is around 10 to 11 millimeters, we say you have congenital stenosis. Something that's really a remnant of the past, the Torg-Pavlov ratio. That was really just for x-rays, less than 0.8. It's often seen with short pedicles, and MRI can sometimes overcall it, depending on imaging quality and patient movement, so CTs can be important. So why does this matter? Why does it matter if you have a congenital stenosis? That's if you have a neuropraxic event. So what is a neuropraxic event? That's when you have bilateral upper extremity, lower extremity symptoms. Can vary from minor numbness and tingling for 10 seconds to complete paralysis for a very long time. It's a spinal cord event. Really, really important. Stingers are nerve root and brachial plexus problems. A neuropraxic event is a spinal cord problem. And imaging is often negative. These are also called spinal cord concussions. Concussions, brain injuries, very confusing injuries. But one of the concretes in concussion is that standard imaging is negative. So CT and MRI are negative. Same thing for spinal cord. If we have a neuropraxic event and the MRI is normal, we call it a spinal cord concussion. And look at the Venn diagram there. There are neuropraxic events that can happen without stenosis, and you can have congenital stenosis and never had a neuropraxic event in your life, but these often coalesce, and that's when we see them in clinic. The most basic form, again, neuropraxic events are cord problems, stingers are peripheral root and brachial plexus issues. So now moving to the second part, contact sports. This is the old way we've described contact sports historically, and it's probably adequate for ACL injuries, ankle sprains, but when it comes to what we deal with, catastrophic spine injuries, it's really inadequate. In a Delphi study that we embarked on that I'll go over in a second, we really, at the outset, revised this to look at these two factors, right? Look at something like equestrian or gymnastics. These are not contact sports. Because of the speeds involved, there's a not insignificant chance of having a catastrophic spine injury. So those have very high impact forces. Then you look at frequency of impacts. In a sport like basketball, where there's a high frequency of issues, but the impact forces are relatively low. So that led us to categorize sport in a different way. On the left-hand side, you see frequency, low and high. On the top hand, you see impact forces. And on the bottom right are the classic collision sports. Level 3 are high impact forces, but low frequency. And to us as spine surgeons, that really matters a lot. And level 2 and level 1 go forth. So now talking about some of the literature that we have. And just to back up, what's our role here, right? What's our role as spine surgeons? Friends, colleagues will often ask, would you allow this athlete to play? And they'll go through the story. And that's rarely what we're doing. We're not giving a thumbs up or thumbs down. We are advising, we're breaking down, we're explaining things, and most of the time you're letting the athlete and their family come to what kind of risks they want to assume. Now, we do sometimes say 100% no. There are some contraindications, but most of the time we're learning about the athlete. Is this a 120-pound linebacker going to MIT next year, and the risk of going back to football may not be worth it? Or is this someone whose education and means of income are on the line? These are all really important things. So what's the literature that we have? I won't go over this here, but the same issues that Joseph Torg wrote about 30 years ago, we're still talking about it today. So if you get a chance, read this original paper. There was a great study about 6 years ago now by the CSRS in Jefferson that went through a lot of different scenarios on core signal change and diameter. This was a great study. They simplified and only talked about paralysis. They didn't really define what transient meant, and they only looked at collision sports. And from building on that study is what launched us into a Delphi study that we conducted several years ago. 34 spine surgeons and even ortho-neuro split, and we addressed a lot of these areas in a very granular and nuanced way. And one of the papers, I'll dial down on what this session is about. Congenital stenosis. So what we found in our survey of spine neurosurgeons, spine sports surgeons, is that the only consensus that we had was 2 severe neuropraxic events was a hard no, right? If you've had 2 very serious spinal cord events, the risk is too great. So we agreed you probably can't go back to sport. But if you look at the rest of the scenarios, even though 70% of consensus was not agreed, this data is still really important. So the first one, if you have a short neuropraxic event with canal stenosis, half the group said you could go back to low impact, high frequency sport. 47% said low impact, low frequency sport was okay. 2 short neuropraxic events with congenital stenosis. Some said, about half said you could go back to low impact, low frequency sport, but 20% said no sports at all. And if you had 1 severe neuropraxic event, so greater than 4 hours, but eventually resolved with congenital stenosis, 65% said you could go back to a lower energy sports, and 35% low impact, high frequency. So I go over the data very detailed because I pull this up in clinic. If I have an athlete wrestling with this, I'll go through, this is what all my colleagues said, this is what the group said, so we can educate athletes and their parents and give them an informed decision. Some other clinical pearls that are really important, right? These are long visits. I go over the history, the mechanism. Was this a freak accident in practice, or was this a relatively routine play? The routine plays are a lot more concerning than the rare incidents. When you have a bad concussion concomitant with this, these are often missed. So 2 or 3 days later, the athlete will say, you know what, when I woke up, I couldn't feel my hands for 2 hours. So that's a spinal cord problem, and then we'll often get delayed imaging. I over-image these patients, right? These are high-level athletes, college athletes now. There's often money on the line. So I get everything because I never want to miss it. They're going back to very extreme conditions. There are some contraindications, any instability, persistent deficits, core signal change. There's a great paper by Joe Maroon that said after surgery, once the level's been fused and stabilized, core signal change may not be a contraindication. That's the paper right there. And then importantly, stenosis alone is not an automatic disqualification. And these are the 4 studies, and I put these up here so you can reference these. That was the reason we did these studies for 4 different scenarios, because I guarantee you, even if you don't see athletes all the time, probably everyone in this room has seen some sort of athlete where you were wrestling with this decision. And if we don't have data, the answer is no. The answer is no, you can't go back to sport because that protects us, right? We have a lot on the line, seeing 20, 30 patients in the clinic. So hopefully we can use the data that our group came up with to allow people to go back to sport, especially kids, right? Because this is all what we want to avoid, because sports can be a very meaningful experience, and I'm sure we all remember our sports days fondly. I'll close with a couple cases. This was a 17-year-old male basketball player we saw, a very high-level athlete, had a very rare accident, dunked, hung on the rim too long, hit the back of his neck. He was out for like 3 hours. He eventually came back, and by 6 months, he was neurologically normal. And you see, his canal was mostly wide, but he did have one area right around C3 where, at least on supine imaging, the cord was touching the back of his ligamentum flavum there. So he had congenital stenosis, had a severe event, but it was a very rare mechanism. The chance of this happening again was low. So we counseled him, went over everything. He decided to go back to play, and he has not had issues since. Case 2, this was an 18-year-old high school football player, had a very minor event, hit during a game. It lasted about 5 minutes, just numbness, no weakness. He did have legit congenital stenosis. And long story short, this was his ticket to education. So hearing all the risks, he returned the same season and has had no issues. And Anthony's given me permission to share his story. He's had a very productive college career. And I'll go back with the last 15 seconds here, go back to our original case. So let's break this down. Why is a 2-level CDR, in my opinion, not the appropriate management? So this is a stinger problem. This is not a bilateral cord problem, right? It's a nerve root issue, not a spinal cord issue. So a cervical disc replacement addresses his congenital stenosis that he has radiographically, but it's not a functional problem for him. So it was also the off season. So the best thing we can do for these athletes is to rest. So we rested him and counseled him. If he returned, if these stingers came back, a foraminotomy would treat his symptoms. So we'll go over, rush through these conclusions just to say we stand on the shoulders of giants, right? So thank you to all the spine surgeons who have come before us that have allowed us to play a role in sports. And these are the two very high maintenance athletes I deal with on a daily basis. So thank you.
All right, Scott, real quick, while our next speaker's coming up, is there an understanding of the relationship of the incidence of spinal stenosis in the contact sport athlete to the general population? Is it overrepresented in the contact sport athlete?
Yeah, no, we were just talking, and we anecdotally see that overrepresentation of congenital stenosis in these athletes. Short answer is we don't know. You need a large population study with a lot of MRIs in elite athletes and normal individuals. So we don't have that data, but I think anecdotally, you're right. I do see that as well, and it's all at C3-4. They usually have a lot of problems at C3-4.
Great. Thank you.